Yeah, thanks a lot for the invitation, and we'll present you today some important aspects of lung transplantation in PAH. As you just heard in the previous talk, there are tremendous improvements in the medication for pulmonary hypertension. However, lung transplantation still is an important option and should be considered not too late, as I will show you. So I want to give you a brief overview on the current status of lung transplantation with a particular focus on PAH. And then I specifically want to go into detail on referral and listing, and also on the options of bridging with extracorporeal devices for PAH patients. And in the second part, talk more about the surgical details and type of procedure and what specific peri and postoperative challenges we face in patients with pulmonary arterial hypertension and what outcomes we are able to achieve. So the first lung transplantation, as you might know, took place already in 1963, and since then a continuous increase in numbers has been observed worldwide. However, patients with pulmonary arterial hypertension only account for a small fraction of these patients. Here in the data of the ISHLD registry, basically they are summarized in the other group. And if you look more into detail, it's a fraction of about 2 to 3% of patients who actually undergo lung transplantation with this diagnosis. This means that the evidence is mostly limited to single-center retrospective analysis, and larger prospective multicentric series are not really prevalent. In the pediatric population, pulmonary hypertension accounts for a larger fraction of the patients. Here in the yellow, the IPAH, and in red, the other patients with PH. So when we look at our own centers numbers in Vienna, we do about 100 to 120 transplant procedures a year on a constant basis throughout the last years. And if you look at the different indications, you see here in dark blue the patients with pulmonary hypertension, and this also accounts for a fraction varying from year to year, but around 4 to 5% of patients. So when is the ideal time of referral and listing for lung transplantation? The important thing is, as you all know, the status can deteriorate very quickly in PAH. And the important aspect is to build a safety net in case this acute deterioration occurs, and ideally have an idea about suitability of transplantation and the evaluation, if necessary, before this deterioration occurs. When you look at the guidelines of the European Society of Cardiology and the European Respiratory Society, in the different types of pulmonary hypertension, you see lung transplantation is a therapeutic strategy in PAH, meaning type 1. And if you look more in detail, for example, what has been discussed recently in the World Symposium on Pulmonary Hypertension, when the initial risk assessment takes place, this is based on several factors such as functional class, 6-minute walk distance, natriuretic peptides, hemodynamics, RV imaging, and other measures. These measurements put the patient in a certain risk category. And the transplant referral should be considered early on for selected high-risk patients already at the stage of diagnosis, and for intermediate high and high-risk patients at the first or subsequent follow-up. As we all know, the urgency and the risk category can change throughout time, and even patients who are not in the high-risk category at the beginning can deteriorate and get into this high-risk category. Why is it important? Because we know that the urgency of lung transplantation is a clear predictor for the postoperative outcome. And patients with fulfilling high-risk criteria, whether it is according to ESC, ERS criteria, according to the REVEAL or COMPARE methods, all these patients have a worse outcome if high-risk category criteria are fulfilled. When we look at what's actually happening in referral of patients, there's a very recent analysis from North America published in June this year in the Journal of Heart and Lung Transplantation, which shows the reality of referral in PAH patients of the Pulmonary Hypertension Association Registry. And you can see that actually in about 1,670 patients analyzed, only 200 of them were actually referred for transplantation. There are several factors which indicate whether a patient is more likely to be referred or not, particularly the diagnosis of PVOD being an important issue. But the overall summary is that the rates of referral for lung transplantation in patients with PAH remain unacceptably low and occur too late. And an increased awareness of the benefit of early referral is necessary, even at expert centers. So why is it important? Of course, we do not wait until the patient is decompensated and has a poor muscular status and a lot of side problems occur, because then the risk for the transplantation and the perioperative recovery is, of course, much more difficult compared to if the patient is in a better shape. And these late referrals lead to an increased perioperative morbidity and mortality, and ultimately makes it difficult to achieve the outcome we want to have for our patients. So, of course, we do have options available in case an acute deterioration occurs to bridge to the transplant procedure with the use of extracorporeal devices. However, we want to try to avoid these situations as much as possible. So what are the basic principles? Usually the deterioration occurs because of an impairment in the right ventricular function and in the hemodynamic situation. So thus the idea of bridging with ECLS, meaning extracorporeal life support, is to provide hemodynamic stability, to relieve the right heart, and to protect the kidney and the liver function. There are several technical options available. The right ventricular bypass is not sufficient because we need to bypass the pulmonary circulation in order to relieve the heart and improve the hemodynamic situation. So the standard option is the implantation of a veno-arterial ECMO, which can be inserted in the ICU, even in local anesthesia. However, has some issues, and there are different cannulation strategies available, like in the subclavian artery, central cannulation, or a centrally implanted Nova lung, which all have their distinct advantages and disadvantages, and all have the idea to bridge the patient in a condition as stable as possible towards the transplant procedure. A lot of these ECMO devices nowadays can even be used in a setting where the patient is able to ambulate in a status of an awake ECMO, meaning that even some degree of physiotherapy or mobility on the ICU, or as shown in the example here, even temporary transfer and on the hospital premises outside the ICU is feasible in some patients. All these bridging options, however, particularly in the setting of PAH, where a hemodynamic support is necessary, are only suitable for a limited time frame. So, and the actual access to transplantation, of course, heavily depends on the setting you are based and the system of organ allocation. In Europe, there are several different systems of organ allocation in place, some countries with informed consent, some countries with presumed consent, and in some countries, the relatives have a right to object as well. Usually in countries with a presumed consent, the organ donation rates are somewhat higher. However, within even within these countries, there's really a huge difference in the actual number of lung transplants performed per million people. And there's quite a variety. And in Austria, we're here in a very good situation, being able to perform a decent amount of lung transplants per million people. With regard to organ donation and how organs are actually procured and preserved, there really have been major advances in the last years. I can't go into the details of all of them for time reasons, but really the advent of 10-degree storage and ex vivo lung perfusion have opened up a broad opportunity of utilizing donor organs that would not have been used before, and allowing a more elective timing of the lung transplant procedure itself. So basically, the main summary in terms of referral and listing is don't wait too long. We have detailed referral and listing criteria. However, whenever there is a doubt, early contact and referral for evaluation of the patient is really an important issue in order to avoid situations where we have to get into bridging of patients, which, however, of course, if the situation occurs, is technically feasible, and a lot of advancement has been achieved in this field. So when it comes to transplantation, what's the ideal procedure performed for patients with PAH? There are several options available. Initially, combined heart and lung transplantation has been performed. However, it has been shown pretty early on that the right ventricle, which here on the left side is hypertrophic, enlarged, and with an only small left ventricle, can really nicely recover after the transplant procedure to an almost normal situation, as shown here on the right side. And also the survival outcomes have shown that a bilateral lung transplantation is associated with comparable outcomes compared to the initial heart-lung procedures performed. So this has become the standard of care for patients with PAH. Doing a single lung transplantation, which would be a technical possibility, is not recommended because due to the prevailing increased pulmonary vascular resistance in the non-transplanted lung, all the volume goes to the newly transplanted lung, leading to a volume overflow with initial hemodynamic instability and a higher rate of primary graft dysfunction, and in the long run leads to a ventilation perfusion mismatch between both sides. So this is not a recommended option. Really, to avoid this situation that the full cardiac output goes to a single transplanted lung, a bilateral procedure performed with the use of extracorporeal support intraoperatively is the standard procedure for PAH. From the technical perspective, the surgical access can be gained either by a clamshell incision or by two separate anterolateral thoracotomies. Depending on the situation of the patient, usually thoracotomies are feasible as well, and the cannulation is usually done in a central way in the aorta and in the right atrium. The surgical technique itself is pretty much standardized for lung transplantation and is in PAH patients comparable to any other transplant procedure, of course, with some particular issues regarding the management of the heart. But basically, a bronchial, atrial, and an arterial anastomosis are performed, and this procedure is done bilaterally in a sequential way. The main issue in PAH are the peri and postoperative challenges associated with the disease. So we do know that the early postoperative period is tricky regarding the management, and this is the highest risk situation in IPAH patients. Whereas if this initial critical period is overcome, the long-term outcome for PAH patients are among the best that can be achieved with lung transplantation, and really excellent. So the main issue in the postoperative phase is not anymore the right ventricle, because if the increased pulmonary resistance is gone, the right heart quickly recovers after lung transplantation. And here are some images which nicely demonstrate this. It's always pairs of the same patients, where on the left side, you can see the massively increased size of the heart prior to transplantation and the complete recovery to a normal cardiac size after the transplant procedure. And this is really observed in those patients typically after bilateral lung transplantation. The main issue, however, is the left ventricle, which gets a lot of volume through those lungs, which is not used to. And there are several strategies that need to be addressed to avoid this left ventricular decompensation. One important issue is a prolongation of the extracorporeal circulation support into the postoperative period. And we have shown that this routine prolongation into the postoperative period really leads to increased survival rates compared to if this postoperative prolongation is not used. And then there are several other management strategies like fluid restriction, early initiation of hemodialysis if required, which does not impair kidney function in the long run, but really leads to excellent outcomes regarding the weaning and the critical postoperative period. And adding all these management strategies in the perioperative setting has really been able to substantially improve the early and long-term survival rates of PAH patients, as shown in the survival curve of patients transplanted for this indication at the center in Vienna, and really excellent long-term survival rates and quality of life can be achieved. So in summary, with regard to the operative setting, double lung transplantation with intraoperative veno-arterial ECMO is associated with excellent outcomes. Acute left ventricular failure is the main challenge in the early postoperative phase, and how this excellent long-term outcome and quality of life translates into real life. I want to show you with a few slides. We had some expeditions organized by Peter Yaksha, our transplant pulmonologist, initially to Kilimanjaro and also to Jebel Tukkal, as shown here with patients after lung transplantation. And this really demonstrates how excellent quality of life can be achieved after the transplant procedure. And we're taking this one step further in January next year, and with a group of patients in an international European and North American collaboration, going to try to summit Mount Aconcagua. And this, of course, is only possible with really an excellent and dedicated team, which we do have here in Vienna. And with this, I want to thank you for your attention and look forward to questions.
Thank you very much, Professor Aigner. We have one question from Bruno. In light of emerging evidence on remission potential and pronounced RV reverse remodeling with sotatercept, to what extent might this translate into a reduced need for lung transplantation in PAH?
Well, of course, all the new medications, including sotatercept, really work excellent for subsets of PAH patients and are able to either reverse existing right ventricular dysfunction or hypertrophy. However, they do not work in all the patients, and in some patients we really have a risk category from the beginning on, where sometimes, depending on how early the diagnosis is made or not, this reversal cannot be avoided in a safe way without having the safety nets in case of an acute decompensation of doing a transplant procedure. So I really think sticking to the referral criteria and a clear categorization in the established risk categories is an important issue, and establishing the possibility of a lung transplant early in the disease does not do any harm, and you always have the option as sort of a safety net in case a deterioration occurs. And if it's not required, we're very happy that we don't have the necessity for transplanting the patient.
Thank you very much.